So welcome back to day 3 of the Law and Policy webinar series. Thank you to all those who have joined our 2 previous webinars, Monday and yesterday. And as a reminder, these will be available in a few days, both as a recording and in PDF format. More information will come at the end of this webinar about how to access those materials. As previously mentioned, this is part of a larger dissemination effort to share information related to our recently released abortion care guideline. And before we dive in, just as we've done the last 2 days, a few housekeeping issues. So number 1, we have simultaneous translation available in Spanish and French. Please click the globe at the bottom of your screen and choose the language in which you'd like to listen. We ask all speakers to speak slowly so that all information can be clearly translated. After the recommendations are presented and after the panelists' discussions have occurred, we will open up the webinar to a Q&A portion. We know that many of you may have questions that arise as we are presenting or discussing, but in all cases, we ask that you place any questions in the Q&A function and not in the chat. This will help us to ensure that we're limiting distractions and allow us to do our best to get to all of the questions. The webinar will be recorded and distributed as mentioned. And on that note, it's time to get started and do some introductions. So first, I'd like to ask Fiona de Londres to introduce herself, please.
Thank you, Antonella, and hello, everybody. My name is Fiona de Londres. I am the Professor of Global Legal Studies at the University of Birmingham in the UK, and I worked with the team in developing the evidence base for the law and policy recommendations.
Great, thank you. Mary Favier.
Hi, I'm Mary Favier. I'm a general practitioner in Cork, Ireland. I'm co-chair of Global Doctors for Choice. I'm an early medical abortion provider in Ireland and was involved in the campaign to repeal and change the law in Ireland, but also the design of our clinical guidelines and the implementation of education and training. I'm a past president of the Irish College of General Practitioners. Thank you.
Great, thank you. And Fareed Abubakar?
Good morning, good evening, good afternoon, wherever you are. My name is Fareed. I'm an associate professor of OB/GYN, working in St. Paul Hospital Medical College in Addis Ababa, Ethiopia. I'm a clinician, researcher, and trainer. I'm happy to be here with you today. Over to you.
Great, thank you. So Fiona, if I could ask you to come in while we set up our PowerPoint presentation.
Sure. So let me just start, as I have done the last few days, with a couple of remarks that will just help to frame the conversation that we're going to have today. And in particular, to remind ourselves that the recommendations in the law and policy portion and what we're discussing today are recommendations that are focused on questions of regulation, law and policy, rather than on questions of service delivery. In other words, they are about the regulatory context in which quality abortion can be provided, accessed, and managed, rather than a set of rules about what people may or may not do in any particular set of circumstances. As is outlined in the guideline, the enabling environment has 3 components, one of which is respect for human rights that includes supportive law and policy. And so that is the kind of focus here on these law and policy recommendations. Secondly, it's useful to remind ourselves that even though there are 7 recommendations in law and policy, and today we'll focus on 4 of them, all of those recommendations are interlinked and interconnected. And so they all relate to one another in practice, as well as in terms of the regulatory design of law and policy in which or through which abortion is provided, accessed, and managed.
Great, thank you so much. So next slide, please. So for those who could not attend the first 2 webinars, we provided an introduction to the guideline, an explanation of our approach, and we reviewed all 7 recommendations, which for the purposes of the guideline and evidence review have been split into distinct interventions so that we could identify the health and non-health impacts. But as we've seen multiple times over the last 2 days, for the 3 that we reviewed yesterday, but all 7 when we reviewed them on Monday, they're all actually quite connected and quite dependent on one another. And so today we will focus on the last 4 law and policy recommendations, and we'll invite our panelists to share their experiences working on these issues. But again, I'll invite you to listen to the recordings from the first 2 webinars for additional details if you've missed them, as well as we'll share a link in the chat to our evidence to decision frameworks where a summary of all the evidence is provided. Next slide, please. So before we do a deep dive into these 4 recommendations, I'd just like to say that the 4 recommendations that we'll discuss today, mandatory waiting periods, third-party authorization requirements, provider restrictions, and conscientious objection, all pose barriers to access to abortion and have negative effects on the exercise of human rights. These barriers emanate not only from law and policy requirements relating to these interventions, but also to how they're implemented in practice at individual and facility level. And as we've discussed several times, women are sometimes subjected to unnecessary demands like requiring additional consents, even when the law does not mandate this. A health worker's refusal to refer the woman to a different health worker who's willing to provide abortion, even if such referral is required by law, or a refusal to trigger the mandatory waiting period until an ultrasound, for example, is provided so that an exact gestational age can be determined. Examples of factors that impact how abortion-related laws and policies are applied in practice to limit access to quality abortion care include a lack of legal clarity, a lack of clear guidance, biases based on personal preferences or opinions, lack of knowledge or understanding of the law, facility-level policy that's more restrictive sometimes than the law, failure to ensure sufficient funding for provision of abortion care through public health systems, financial incentives to divert women from publicly funded to privately paid for or out-of-pocket abortion care, stigma, harmful gender stereotypes, and hyper-cautious interpretation of law because of the criminalization of abortion outside of limited circumstances. So while the full implementation of the recommendations may take some time, it is also useful to look at the setting in which these recommendations exist. What exists within the guidance or protocols that's connected with criminalization and could immediately be changed? What practical steps can be taken administratively to mitigate the limiting effects of the regulatory design? So for example, we talked yesterday a lot about suspending the application of the criminal law on abortion. Let's look at the recommendation for today's webinar and come back to this point with our panelists. Next slide, please. So as mentioned in the first webinar, in many countries, women are required to wait a specified amount of time between requesting and receiving an abortion. These imposed delays are known as mandatory waiting periods. They can be required by laws or regulations and/or administrative procedures imposed by facilities or individual providers. What we know is that they may commence at various points: at the time of request, at the time of consultation, counseling, or at the time that gestational age is determined. They can also vary depending on ground or specific circumstance upon which the woman is accessing the abortion, as well as the gestational age. We recommend against mandatory waiting periods for abortions. Next slide, please. We also reviewed third-party authorizations on day 1, which are requirements imposed by law or policy or in practice that someone other than the abortion seeker must authorize an abortion, even where other applicable legal requirements for lawful abortion have been met. So for example, the person qualifies based on a ground or gestational age limit, or if they've completed some other necessary requirement like the mandatory waiting period, and still an additional authorization is required, perhaps by a parent, a guardian, a spouse, a health worker, a health authority, a judicial authority, or a committee. As mentioned, these requirements operate whether or not the person who seeks to end a pregnancy has the capacity to consent to medical treatment, meaning there's no consideration to those with the ability to consent or the evolving capacity by minors to do so, which is often done for other services, including antenatal care. We recommend that abortion be available on the request of the woman, girl, or other person without the authorization of any other individual, body, or institution. It should be noted that involving a parent or partner in the decision-making process must be the pregnant person's choice and not a result of requirements of third-party authorization. Next slide, please. In many countries, law and policy restrict which type of health workers may lawfully provide abortion care, despite the fact that abortion can be safely done using tablets or a simple outpatient procedure, such that most no longer require a specialist or even a general practice doctor. The Abortion Care Guideline provides guidance on how to involve pregnant individuals themselves. Specifically, we have recommendations related to self-management of abortion, as well as a wide range of health workers in abortion care, which is consistent with WHO's support for the optimization of the roles of health workers. We recommend against regulation on who can provide and manage abortion that is inconsistent with WHO guidance. Next slide, please. And finally, we reviewed conscientious objection or conscientious refusal on day 1, which is the practice of healthcare professionals refusing to provide abortion care on the basis of personal conscience or religious belief. In some countries, conscientious objection is expressly regulated through employment law, employment contracts, or the law on abortion. WHO has also advised that health services should be organized in such a way to ensure that an effective exercise of the freedom of conscience of health professionals in the professional context does not prevent patients from obtaining access to services to which they are entitled. We recommend that access to and continuity of comprehensive abortion care be protected against barriers created by conscientious objection. It is critical that states ensure compliance with regulations and design or organize their health systems to ensure access to and continuity of quality abortion care. Next slide, please. And just to quickly highlight, here are some of the outcomes we observed in the data. And again, you can please link to our evidence to decision frameworks for more detailed information about these outcomes. So now we will turn over to our panelists for our discussion. So first, I'd like to ask Fareed to come in at this point. And I'm wondering, it can be very challenging for a healthcare provider confronted with an adolescent or a person with potentially diminished capacity who seeks abortion, but who says that they don't want to tell their parents or to have any other party involved. So what can we do to try and make sure that people are supported or protected in making these decisions? And how can providers feel more protected from lawsuits or blame by their parents if they do find out, for example? Fareed?
Okay, thank you, Antonella. I think this is a very important question. In most circumstances, providing any type of health care to adolescents is a very controversial issue. It is going to be even more controversial when it comes to sexual and reproductive health in general, and specifically to abortion care. So the possibility of requesting authorization from a parent or a guardian or any other third party is not something that we consider feasible. It's very unlikely that a teenager will come with a parent to the clinic requesting for contraception or abortion care. And we know having such requirements can significantly restrict access. The same is true regarding care of a person with diminished capacity. So as a practical example, I can mention a few ways how this was addressed in the Ethiopian context. So just to give you some background, like most countries, the abortion law in Ethiopia lives in the criminal code. And like most countries, there are certain grounds to be eligible for safe abortion. But the very same criminal code has given the mandate to the Ministry of Health to produce an implementation guideline for care providers. Basically, this is a clinical handbook or clinical guideline that we use in our daily activities in the clinic. So according to the code, both minors and those with diminished capacity, be it physical or mental, are eligible for abortion care. But the clinical guideline goes a little bit deeper and provides more detail as to how this is to be interpreted. For example, as it comes to the adolescents, the providers are expected to use the age stated by the client, and no additional proof of age is to be asked. So anyone under the age of 18 will be automatically eligible for quality abortion care. In addition, minors and those with diminished capacity are not required to sign a consent form. By this, we're not saying, it does not mean that counseling and information provision to obtain informal consent does not happen. We're just saying the need to sign a consent form is waived for this group of clients. But having these details by itself, may not be enough to guarantee care providers. So the guides also state that providers are protected from any prosecution if the initial information provided by the client is later found to be incorrect. So I think this is very important. I believe this is very reassuring to the care provider, and at the same time, it encourages detailed discussion with the client and appropriate documentation of the interactions. But as much as the clinical guideline is helpful to ensure access, it's not without limitations. Sometimes dealing with clients who have mental deficiency is not always easy or straightforward. We know some institutions have attempted to address this through a multidisciplinary team composed of social workers, psychologists, clinicians, but for obvious reasons, not all institutions will have the capacity to do this across the country. There will be certain limitations to this. And I think this is probably one area where there is an opportunity to provide more guidance to improve service delivery. And in addition, we also witness some providers will just refuse to provide care by applying their own interpretation of, their own strict interpretation of the law. And this will ultimately will have a significant impact on access to abortion care. Over to you, Antonella.
I think I'll just come in there, Farid. Thank you for that answer. We'll come back, I think, to this question of, interpretation or providers not giving abortion in line with the law probably a little bit later. But I just wanted to pull out from your answer, in particular, the role of that guidance from the Ministry of Health. So we've seen already in our other webinars this week that those kinds of documents, which are not legislation passed by Parliament, can be really key as a location for advocacy and for trying to ensure that abortion can actually be provided and access to the maximum availability under the law as it already exists. So I noticed there, that your example from Ethiopia showed really clearly how the law itself, in your case, the criminal code, could state the entitlement of young people and people with diminished capacity to abortion, but then the code could both provide a kind of way of working that entitlement, particularly saying, if a person says they're 18, they're 18, and you don't have to do anything else. And then also reassuring providers that that's sufficient to stop the application of any kind of criminal liability. So it's an interesting combination, and one that people may find it useful to think through in their own settings of the legislation and the ministerial direction or interpretation then as well. Mary, if I can turn to you for a second. In Ireland, the abortion law expressly says that the usual rules of consent to medical care would apply. So there are no special rules or extra requirements for young people, adolescents, or for people with disabilities or diminished capacity. And I was just wondering, in your experience, how is that working? Are there still challenges within provision, and notwithstanding the fact that the law says no third-party authorizations are required?
Thanks, Fiona. Just as a matter of context, when the new law was being proposed, coming up on 4 years ago now, after the referendum in Ireland that removed the restrictions in the Constitution, there was initially a proposal in the law that it would only be those aged 18 and over. And there was a really consistent and strong request from people who were opposing abortion that should be the case. And it was only when it was pointed out to the Ministry of Health who were drafting the law that this would then be inconsistent with other healthcare legislation that it was anybody who's age 16 and over is entitled to access healthcare and can consent for procedures, that there was a decision that it would align with that. So so it is an interesting point that from the very beginning we had to be vigilant about that to make sure that those age 16 and over, could consent entirely without a third-party authorization. So, however, in Ireland, there is an accepted standard, and a clinical standard that those under the age of 16 can consent to certain healthcare procedures and undertake actions in healthcare, that even if they're not 16. So a lot of the guidance around this would come from the Gillett judgment in the UK and the Fraser advice that followed, that if you can determine that somebody who's under the age of 16 displays and demonstrates competency, which would generally be 14 and 15-year-olds, that it is entirely appropriate that they would consent to undertake and access healthcare independent of parental or guardian supervision. And so general practitioners in Ireland who are the providers of an early medical abortion service up to 70 days, the law allows up to 12 weeks. So from 10 weeks to 12 weeks is done in conjunction with the hospital service, but up to 70 days is provided by general practitioners, family physicians as they would be known elsewhere. And that service, so those general practitioners would be well versed in the provision of care to those who would be younger than the age of 16. However, and they'd be well trained in that, and it would be very rare you'd come across a general practitioner who would, for instance, refuse to prescribe contraception to somebody who was 15 and a half, for instance. However, when it came to writing the guidance, and the Irish College of General Practitioners wrote clinical guidance for general practitioners in this area, and I was involved in that authorship, there was a lot of concern expressed about, could we apply our usual custom and practice to the area of abortion care? And there's no clinical evidence that we shouldn't. It would be entirely appropriate that we would continue to do so, and that we would respect patient autonomy to make their own decisions once they were competent. However, this received considerable pushback and a lot of caution, and it's a real example where the internalizing of some of the problems with criminalization and conscientious objection around abortion care then gets internalized even into guideline makers and guideline writers, and myself included. And it really means that we need to be very vigilant that we do not treat this, we do not other abortion care, that it is treated as a part of general reproductive health care. So our guidance was written in a very cautious way, and the language is exceptionally cautious. And I even look back on it now that the WHO new guidance has come out, and I've looked at it in a different light and say, we need to go back and revisit that, because we are sending very subtle subliminal messages in the language that is used that suggest caution, suggesting step back. And our guidance is very physician-centric rather than patient-centric when I now look at it and reframe how it should be written, and that we need to keep the patient front and center of our care, but front and center of the guidance we write to provide advice to others. And so there's a piece of work to be done in that area alone. And it also then applies to the area of diminished capacity, where we've taken a potentially overcautious approach that doesn't enable or support abortion care or patient care. So there's things for us to think about as a result.
Thanks for that, Mary. I think it's also, as Fareed's example around the ministerial guidance shows, so yours shows that there are these processes, let's say processes of translation from law to guidance for clinicians or other health workers, where even, let's say, law that seeks to normalize or, that structures provision of abortion the same as other parts of healthcare here as with consent. Within that process of translation, as you say, that kind of caution or conservatism might come into that guidance to actually make the law less accessible and make abortion less accessible than the law suggests that it should be. And I think ensuring, as you said, that kind of consistency, if possible, between how healthcare is provided in other contexts or other forms of healthcare are provided and abortion care is provided is sort of key to understanding this recommendation around third-party authorization and ensuring that those practices around consent and informed consent, on which, as you say, clinicians and health workers are very familiar, they do it all the time, that can simply be done in the same way in the context of abortion provisions.
Because the overarching issue as well as another strand of the guidance is around the criminalization of abortion care and the importance of decriminalizing, because there's such caution in our law, and abortion is decriminalized for the patient, for the women, the girls, and anyone who can become pregnant, but it's not decriminalized for the provider. There's a 14-year criminal sanction, and that has a deeply chilling effect. And while we have a clause in our law that says the physician will act in good faith, and that's our protection, to go back to Farid's point earlier, but it's not considered enough of a comfort blanket. So we end up being overly cautious because of the criminalization. Thank you.
I think that's a great point. We saw it coming up in the webinar yesterday for people who were with us as well, that criminalization really colors or chills more or less everything we do in terms of regulating abortion, so that's a key point of connection between all the different recommendations is what criminalization actually produces in terms of caution, interpretation, and so on. And I mean, just thinking back to what both of you have said, you know, we see, just to pull out a few themes, this question of normalization, the role and potential of documents that fall into the category of policy, like guidelines or interpretive documents or principles that come from professional organizations, are really important. But I just wanted also to note, you know, so that we recall this, that both young people and people with disabilities or diminished capacity have an internationally protected right to the highest attainable standard of health, including sexual and reproductive health. They have a right to have their views taken into account. They have the general international human rights law rights around informed consent. And so part of perhaps what is important to remember is that a recommendation against third-party authorization requirements is simply, in a way, a recommendation to ensure that those already protected international human rights laws are respected, protected, and fulfilled in the context of the provision of sexual and reproductive health, including comprehensive abortion care as well. So yeah, there were very rich answers. Thank you.
And an important issue is this issue of that we apply the same standards to the minors and those who mightn't consent, and I mean positive standards. So one of the issues in our guidance is that it's written very strongly that you should consider social work involvement, or you should consider hospital referral, that you for no other clinical reason might refer to the hospital. But we know that if you refer to the hospital, you will trigger social work involvement, because that's the regulatory framework they work in. And so I think we need to be very careful that we're somehow setting another standard that puts other things in train, that the patient then doesn't get the same access and doesn't have the same rights and entitlements. So we need to be very careful about unexpected outcomes that can occur.
Thank you. Yeah, I mean, this is all talking about this regulatory framework, but we also have sort of this separate issue about the fact that some providers may choose not even to engage in this at all. I mean, you're talking about the ways in which you were actively involved, and Farid is talking about participation by providers in Ethiopia. But for a lot of the reasons that you've raised, including some of these internalizing aspects, we know, for example, that some providers are using conscientious objection as a way to avoid participating in care. And so, Farid, maybe if I can turn back to you for a second. You mentioned earlier providers refusing to provide by applying strict interpretations. Can you speak a little bit to the experience in Ethiopia as it relates to conscientious objection and what you're facing now? And also, just to flag, there was a question in the Q&A about access to the Ethiopian documents, and all of that information is also available on our Global Abortion Policies database. So we'll drop a link to that in the chat. Go ahead, Farid.
Antonella, I think the issue of conscientious objection is becoming a very challenging subject here in Ethiopia. So generally, we know most care providers are very supportive of SRH services, but we have to understand this conscientious objection is a very complex issue. Like we have witnessed some care providers, like there are different variations, okay? Like some care providers will not provide to a certain type of contraception, for example, say permanent methods. Some providers will not be willing to provide care for teenagers, and some care providers will not be willing to provide abortion beyond certain gestational age. But all this spectrum, whatever it is, can have an impact on service delivery. In our case, conscientious objection appears to be a new phenomena. Nowadays, it's becoming, we are seeing it coming to the surface in the past few years, and we are already witnessing now how this rising trend is already compromising the health and right of clients, to the service they are already entitled for, now that they're not getting it. And in fact, there is a very recent study that's reported about 50% of midwives have opposition to abortion care to some degree and form, and we find this very concerning, giving midwives form a large bulk of the healthcare provider caring for those who are seeking for abortion. One possible reason that comes to my mind is the generational gap that we have at the moment. What do I mean by that? So it appears nowadays we have two generations of care providers. This is particularly true for the OB/GYN community. So there is the older generation who are very instrumental in changing the law back in 2005, and these people have served as expert witness during the parliamentary hearings. And again, this is the very same generation that witnessed so many maternal diseases and worked during the era of what we call these septic rooms from complications of unsafe abortion. And there is the newer generation, the current generation, obviously is not faced with such cases, and in most cases, tend to be very indifferent when it comes to advocacy. So this takes me back to the second possible explanation. This is how abortion was framed at the time of revising the law in 2005. The main point was about reducing maternal mortality. How can we reduce maternal mortality was the center of discussion, and still many argue, reducing maternal mortality or the high maternal mortality should be the reason. Addressing the human right aspect was given very little attention at that time, and I believe going forward, this is one area where we must work on, and this has to be emphasized during the pre-service training for medical students, midwives, or whatever, and this has to be continued during the in-service training. At the same time, other countries can learn from this as well. Both the public health and the human rights aspect of abortion care should be, should form the basis for any kind of reform. But at the end of the day, it will be up to the state to effectively regulate and oversee practices. Okay, so it is the responsibility of the state, to be proactive and take measures to ensure access to abortion care, and timely access, in fact, that women and girls should be getting. And there are different measures that states can take. I'll just mention the example of the Ethiopian context. So one of the things that is done is the task sharing and the task shifting. Okay, ensuring adequate number of care providers that are willing and capable of providing care is was a very critical instrument in ensuring access. The other is there are some protocols that Ethiopia has signed and ratified. One of the things that we can mention is the Maputo Protocol. So the Maputo Protocol, particularly Article 14, is talking about providing abortion care based on certain grounds, which are also in line with the Ethiopian criminal abortion law. But again, the Maputo Protocol have a specific section that addresses the responsibility of states in ensuring the availability of infrastructure, referral mechanisms, how institutions are not allowed are not allowed to have conscientious objection, and even providers will not be in a state, will not be allowed to have conscientious objection when there is an emergency. So Ethiopia has signed and ratified Maputo Protocol, but again, like close to 90% of countries in Africa have signed, and close to 80% of countries has already ratified Maputo Protocol. So using this tool as a way of enforcing and monitoring regulations is one option. The other option in Ethiopia that was actually done is there was a bill that was introduced I think late 2013 or early 2014 that specifically addressed that refusal or denial of care based on grounds of conscience is not allowed for any healthcare provider. And that bill, in fact, specifically mentions provision of abortion, contraception, and blood transfusion. So that kind of passes a message to the care provider as to what is the expected service delivery from those care providers. Having said that, I think I will probably ask a question to Fiona about in thinking about conscientious objection. What other actions can occur at different levels so that we can ensure better access to quality abortion care.
Yeah, thanks for that, Farid, and for the example that you gave, the Maputo Protocol and the law and practice in Ethiopia. I just want to reinforce precisely what you said, that if we now shift this more broadly into international human rights law as a frame, the core, let's say, proposition there is, as you said, that states are responsible for ensuring that provider refusal does not operate as a barrier to access to abortion. And this, I think, reflects the fact that in international human rights law, the concern is not only with whether abortion is legal, like mere legality is not sufficient. The concern is with whether safe abortion or quality abortion is available and accessible and acceptable and of the right quality. That's the framework from the right to health. So, really, if we think about what can happen at different levels, I think it's useful to look at what international human rights law actually says about conscientious objection as it applies in sexual and reproductive healthcare. The first thing to note is that international human rights law does not require states to allow conscientious objection, but it does permit them to allow it. So somebody asked in the questions about whether, a right to conscience of health workers should be protected in law. And just to make clear that as a matter of international law, there are two parts to that right. One is your right to hold a belief, and that's absolute. And the other is your right to manifest that belief, and that's limited. And one of the limitations is the rights of other people, how the manifestation of that belief might impact on the rights of other people. So when we talk about regulating conscientious objection in human rights law, we're mostly talking about trying to ensure that in manifesting that belief, the rights of others are not undermined or violated. And so international human rights law, like the Maputo Protocol, which is part of regional human rights law, outlines these actions that states can take, as you said, Farid. The first is around the organization of the system of healthcare. So, like ensuring you have sufficient providers who do not have an objection, and ensuring that they are fairly distributed across the country. So they're not all in the capital city and nobody anywhere else could access abortion care. I think, that relates to also what you were talking about, task sharing. That might be one way that a state decides this is how we will try to ensure we have a sufficient non-objecting workforce within the health system. International human rights law also requires states to put in place clear and enforceable regulation of conscientious objection. There are different elements to that, but certainly one element would be to say that there are some circumstances in which you cannot refuse care on the basis of conscience, particularly emergencies. The second is, as you said in the Maputo Protocol, that institutions cannot claim a conscientious objection. Only individuals could claim objection on the basis of conscience. Or that there should be clarity about who can or who may object to different components of care and who may not. So, the exact nature of the regulation and whether it exists in law or guidance or codes of ethics or whatever will vary from setting to setting. But the state's responsibility under international human rights law is to ensure that the regulation exists in a way that ensures refusal does not undermine access to quality abortion, and importantly, to ensure that that's enforceable. So it's not just something that is said, but rather something that has meaning to ensure that these regulations are complied with. So as I said, I think just by looking at that pieces of guidance in international human rights law, you can already see things that can happen at different levels, whether it is clarity in the law or a code of ethics, or even the clarification of values and practices and kind of social regulation by health workers with each other, ensuring that there is non-punitive, that if you exercise conscience, you don't do it in a punitive way, that you always respect the person who's seeking abortion. Those multiple different levels, I think, are available. If I may, I want to just turn to Mary on this briefly, because the Irish law does permit conscientious objection, but it outlines, some requirements to exercise it and some limitations. And in addition, much, although not all, of Ireland's hospital estate operates under the auspices of the Catholic Church, so some have a particular ethos. So what are your experiences there in terms of how conscientious objection is operating, and whether or not the attempts to regulate it are sufficient to ensure that it's not actually posing a barrier to access?
And also, if you could speak to geography, because we've had a couple of comments coming about where providers are placed, rural versus urban.
Thanks. So the Irish law does indeed protect conscientious objection, and that was a very big feature of the discussion and debate beforehand, with very little framing of it in the context of, for instance, conscientious provision and conscientious commitment, which I think is a really important space that we need to be in and we need to expand. And there's been very little discussion of the difference between conscientious objection and conscientious obstruction and convenient objection. And in the Irish context, that's has been an issue. So our medical council regulatory guidance was rewritten when the law changed to explicitly state that it was now okay to participate in the provision of abortion care, because it had been the opposite, because it was against the law. And there's a clear writing that conscientious objection is protected. However, there's also clear subsidiary guidance that in all circumstances of emergency, the provision of patient care must override that objection, but also that there can be no obstruction, there can be no standing in the way of care, for instance, in onward referral, either at all or in a timely fashion. And however, that's where the difficulty falls down, because it may be fine to say that we recognize conscientious objection, but when it effectively then obstructs the service, we have a problem. So we have 19 maternity units, and we now have 11 of them providing abortion services. And that was 10 until a couple of months ago. So we really do have an issue with not all of our maternity services providing abortion care. And there are a number of reasons for that. And it's particularly this geographic issue that the more rural hospitals don't provide care. And that's for a number of reasons. Some of them would say because they're not appropriately funded, whereas in fact there is ring-fenced funding for it, but they've chosen not to spend it or to innovate a new service. But in one of our regional hospitals, for instance, there are four obstetrician gynecologists, and all 4 of them are objectors for religious reasons. Now, so effectively there's no service. So the service is obstructed in that regional area. And of course, we know it has significant impacts and knock-ons to the primary care community provision of abortion services by general practitioners where they're not supported by a local obstetric unit. And all of our research shows that you can almost map a shortage of providers to a shortage of secondary care provision of services. So that then falls into the gap of, well, that should fall to our Department of Health or our executive function, which is our health service executive, to actually ensure that a service is provided even when conscientious objection of the resident obstetricians is there. But there has been no action taken in that area. And it's just been allowed to fall into a gap. And there's various cajoling and encouragement, but no actual firm action. And it's really important when conscientious objection effectively becomes obstruction in a unit, that there needs to be consequences to that. But to date, we have had none. There's no, for instance, reduction in funding, there's no reduction in referrals, there's no reduction in status of a hospital, where there really should be if we were committed to patient care first, and that our aim was to provide a patient-centered service rather than look first of all as a doctor-centered service, i.e. that they can object. We also have the issue in the primary care community provided services that we have a small number of committed conscientious objectors. They would amount to about 10%. However, there's a group in the middle who are almost convenient objectors. They don't educate themselves to, for instance, that they must refer onwards. They don't try to facilitate patients and women who are accessing the service to find them an adjacent provider or make those contacts, when that would be considered standard clinical care in another context of another referrer. And so there's, similarly, to the best of my knowledge, there's not been a single complaint to our regulatory body, the Medical Council, about somebody on the grounds of conscientious objection not being appropriately expressed or handled. So there's a gap there that we really need to work on, and it comes down to a combination of Department of Health action, but it's also around our regulatory body action, but also our educational institutions. That education is provided, to really make sure that physicians, whether they're general practitioners or obstetricians, gynecologists, understand their ethical guidance requirements, and that they must facilitate abortion care, and that we must keep the patient to the center. But there's a very substantial amount of work yet to be done on that, and is potentially one of the biggest criticisms of the implementation of abortion care in Ireland. Thank you.
Thanks, Mary. I mean, that's an excellent point. And we had a comment come in about the issuance of a technical or procedural guideline and the importance really of disseminating that, as well as the educational piece. And so, both you and Farid have talked about the different places in which those educational components are critical. But also in thinking about, the provision of care and sort of provision without discrimination or judgment, we also had another comment come in about the opportunities to think about medical abortion, for example, and who can provide. So, potentially even expanding to pharmacists. So, maybe Farid, I can ask you to come back in for a second, because somebody has asked, is conscientious objection forbidden in Ethiopia, and sort of what is going on with the idea about expanding to other providers, and what strategies have been used to mitigate the laws around provider restrictions? Oh, you're muted, Farid.
Okay, now you can hear me now. Okay, good. So I think the issue of provider restriction and conscientious objection are a bit complex, as I said earlier. Yes, conscientious objection is forbidden in Ethiopia, but the degree or the extent to which that is enforced, monitored, regulated is a different story. So for sure, we have seen cases where some women and girls were actually denied service because of conscientious objection. So even though that is is not allowed according to the bill that was published in 2019. 2013. Yeah, 2013. So yes, then we have to discuss about how that is implemented and how that is enforced. I hope that answers the question.
Yeah, great. Okay.
So the other is shall I proceed to the provider restriction?
Yeah, please go ahead.
So it's a very interesting issue, having provider restriction, because the issue is not just about provider restriction. Okay, it goes beyond beyond who can provide abortion, but also it addresses where can service be provided, because we know sometimes mid-level healthcare providers are working in the primary healthcare setting. So the main thing that always comes is, oh, is it safe? Okay, the safety issue is always raised. Okay, it is safe for abortion care to be provided by mid-level non-physician care providers, or can service be provided in the primary healthcare setting? I think to address this, we can approach it from two very different perspectives. The first one I would like to emphasize is the evidence. Okay, ideally, this is how we want policies, guidelines to be formulated, right? So what is the evidence in terms of safety of provision of abortion care by mid-level care providers? So as you might have seen in the WHO guidelines, there are several high-quality studies that are conducted, across a wide range of settings, and that have looked at this very specific question. And the studies have shown the safety and effectiveness of abortion care provided by mid-level healthcare providers is not significantly different from that provided by physicians. But we can also see how, having abortion care provided by a wide range of care providers can improve access, but at the same time brings other benefits to the health system. This can be, in terms of decreasing referrals, ensuring timely access to care, travel cost, provision of care at primary healthcare units, and the physicians will have more time to focus on more complicated cases. So these are all the additional benefits that we can assume that can come from task sharing, task shifting, and this can have significant cost implication for the health system. The other approach that I would like to emphasize is logic and reasoning. So you all remember with the review of maternal mortality data, we know that the highest risk of death is during labor and the first 24 hours after delivery. Indeed, one of the recommendations from WHO is, increasing skilled birth attendance. Rightly so, the response from many countries was to increase the proportion of deliveries occurring at healthcare facilities, especially the primary healthcare facilities, and these are attended by mid-level healthcare providers, of course, with a backup to a referral mechanism, should some complication arise. So today in Ethiopia, and in fact in most African countries, low-risk women are attended by midwives at a primary healthcare unit, and this has worked very well. Many countries have, were very successful in reducing maternal mortality by just increasing the skilled birth attendance. So now we should ask ourselves, could we apply the same model of care of delivery for the comprehensive abortion care? It's just logical, right? So in thinking, about all the mechanisms we can, ensure, enabling environment, can we consider provision of comprehensive abortion care service by a wide range of healthcare providers that are already, functioning within the existing system? At the end of the day, it all comes down to the level of training, right? So if we can ensure that providers have the needed capacity and competencies to deliver the care, it is logical to assume that we can safely and effectively expand the range of care providers. And this has worked for so many services, and it's already in line with the existing evidence. So I think this is one opportunity that we can strongly consider. Over to you.
Yeah, thanks, Fareed. I mean, just to tie that up with the human rights law perspective, one of the propositions of international human rights law is that law that regulates abortion should be evidence-based. And as you say, the evidence base is there. And if we know that provider restrictions, in fact, reduce our capacity to fulfill the right to health because, for example, of reducing the availability or accessibility of health goods and services, then you also, in addition to what you were saying, get a rights-based imperative to move away from provider restrictions that do not reflect, for example, the WHO's guidelines about who can provide and manage abortion. Just conscious of time, I would like us to move on a little bit to talk about mandatory waiting periods. And Mary, in Ireland, as many people who are with us will probably know, abortion is available without restriction as to reason or on request up to 12 weeks, but provided that the woman has completed a 3-day mandatory waiting period. What's your experience of this waiting period and its impacts on access to abortion?
Firstly, as we know, there's absolutely no clinical evidence to support mandatory waiting periods, and they've been refuted from an evidence point of view, internationally across the world. So this was a hard-fought issue when it was being proposed in the legislation, and was commonly accepted that it was to appease some of the anti-abortion politicians that it was introduced into the law. And we knew it would be problematic, and indeed it is. So we have a scenario where a woman seeks and requests an abortion from any healthcare provider, but it must be from a physician. And then the certification is signed, and 3 days after that, she's entitled to access the service. But of course, by definition, if she tries to, that's fine if it's on a Monday or a Tuesday, but if she tries to access the service on a Wednesday, the 3-day wait applies and it takes her to the following Monday. And indeed, if it's a public holiday, it takes her to the following Tuesday, and potentially even longer delays if we're in festivity times such as Christmas and the like. So it's really problematic in terms of how care is delivered. The other issue that arises around mandatory waits is who considers themselves the appropriate person to certify. And the law states that it can be any physician. So it could be, for instance, a cardiologist or an endocrinologist who knows this woman has a healthcare issue and is going to access an abortion. However, in practice, what happens is the woman then gets referred to a potential abortion provider, and only then does the certification get signed. And that's for a number of reasons. It's because other specialties conveniently don't engage in the process and refer on. They potentially don't understand the harms that come from an imposed wait. But also it's a way of othering abortion care and keeping it completely separate, to other aspects of the health services that would normally be integrated. So inter-referral pathways in our hospital services are well established, and we would not usually have this handover of a regulatory sign-off. So, and that's again comes back to the really important, if you're trying to mitigate these mandatory waits, that you really look at where are the barriers, where are the obstructions, where is the lack of education, where is it potentially being used as obstruction. And again, it comes back to this issue of the criminalization. Again, because this is written into our legislation, it's not a regulatory issue, it's the legislation. Abortion providers, in our case, family physicians, general practitioners, are really quite caught up that the certification is appropriate and is recorded. And we have scenarios, particularly when we have women up against the legal limit of 12 weeks, where, and in our scenario, it's a 12+0 legal limit, not 12+6. We will see a woman, for instance, at 11+3 days, and we won't be providing the service in the community, but we'll be making the referral on, we'll be certifying, and you'll be knowing that that 3-day wait will now happen on a Saturday or a Sunday. And there is a scramble then to try and line up abortion services, which should be absolutely routine like an MVA, but across a weekend service. So they're really, really quite problematic. Now, we had an emergency regulation passed during COVID regulations that's still in place, that allows the derogation of that, just to step back a bit, there's also a regulation in our law that not only is there a 3-day wait, but you must be seen in person 3 days apart, that you must physically attend. And that was again detailed very much into the law. So we've had a derogation for a COVID, because of COVID infection, that could now be done virtually or be done by a telemedicine. And we've found to great assistance in patient care that it has really mitigated one of the harms of the 3-day wait. So the first visit can now be done on the telephone, and then 3 days can take place. And that has really helped, because it used to be a scenario if a woman contacted me on a Tuesday afternoon and then she might attend on a Wednesday for an appointment, she's now triggering an actual 5-day wait, not 3 because of the weekend. But we can now make the Tuesday the first of the 3-day waits. So that has mitigated it. And we are really making a strong case that that should now be retained as best practice, best patient care. But it has improved the 3-day wait, which we continue to argue has no basis in medical care.
Mary, can I pick up on something that you mentioned? So, thinking about other types of providers who may not want to be involved, or, we had a question come in about the lack of knowledge or stigma with other healthcare professionals who aren't providers. And so how we can, work with those individuals. Do you have any experience with that in Ireland?
We have this situation where, again, because of not just the criminalization, but also the shaming and othering of abortion care, that it's very much, behind closed doors. Most physicians do not need to know or want to know anything about it. And so there's a significant piece of work that needs to be done to educate all healthcare providers, but most particularly, secondary care physicians, that they have a role and a responsibility in this legal requirement for certification. And again, it's around our Department of Health and our education establishments to make sure that education takes place, and that there is actually an ethical requirement. This is another example where our regulatory bodies, like the Medical Council, need to take a more active role, that there is a regulatory requirement that you provide that certification. There's no specialist knowledge required. It's a knowledge of the law. There's no reason why any physician shouldn't have a knowledge of the law.
Great. Okay, thank you. Fareed, did you have any comments on that, in particular about dealing with stigma? In particular, we know that there are multiple touch points that an individual may have as they access care, whether within a facility or not. And so thinking about stigma and tackling that.
I think mostly the healthcare providers will have a significant role to play. I think, people who have, conscious people who have made the decision to be provider, they are the ones who should be providing the service. Just like it was discussed yesterday, we don't want, the care to be provided with someone who are not willing to provide it. So that kind of, forms a vicious cycle of having stigma and discrimination against women, against providers. So I think having that informed choice to provide the service is really important for the provider, also at the same time for the woman.
Great. Okay, so we've been taking questions as we've been speaking, so it's really great, and we'll keep encouraging individuals to post in the Q&A. One question that came up based on something actually you said, Fareed, early on, which was this idea about generational issues in terms of advocacy and indifference. And so we'd love to hear from both you and Mary about how you see this playing out in terms of health professionals and the willingness in particular of younger generations to gain that training and to actually be able to provide and to be supported in their provision. So maybe Fareed, go ahead first since you brought it up, and then we'll turn to Mary.
Yeah, so this generational gap is, I think it's a huge problem for us. As I said earlier, the main reason why the older generation, were arguing and played an instrumental role in revising the law is because they have seen the consequences of unsafe abortion. This is very good, but at the same time, the human right aspect was not even addressed at that moment. It was all about reducing maternal mortality. So, they are a very, strong advocate of, ensuring access to safe abortion. But nowadays, because we don't see complications of unsafe abortion, then newer generation of care providers, will not be, very much interested in arguing for or advocating for safe abortion. So I think one thing we can do to close the gap is, talk about what was the consequence, okay? What was the issue that we had like 20 years back, and trying to emphasize what safe abortion care service mean to women and girls, especially in those who are marginalized, living in the rural setting, where they will not have access to care because of financial and other social constraints. So that has to be emphasized. And again, this should be part of the pre-service training and should be taken to the in-service training. But to be a provider, I don't have to see data every day. Like it's not only data that should make me try to be a abortion care provider. That's where the human rights comes to picture. So we have agreed that abortion care is a healthcare, and we have said healthcare is a human rights issue. So we have to frame it that way for the coming generation.
Great, Mary, what's here?
We have a slightly different experience. Our experience is that our older physicians, our older doctors, and most particularly our obstetricians, gynecologists, would be historically very conservative on this subject, and would have been traditionally, if not anti-abortion themselves, presumed to be anti-abortion. And all the institutions, the royal colleges of whether it was physicians, surgeons, general practice, historically, before Irish independence, and we had our own college, they would have all been historically anti-abortion. So we have that historical legacy. And we have the exact same point that Farid has, that because we've had so much, in Ireland, we always had the safety valve of traveling to England to access abortion. So we had very little experience of the complications of unsafe abortion, and very few tragedies. So we didn't have that priming of physicians to really want to help and assist. However, with the change in the law, what we've noticed is that there's a huge appetite amongst young doctors, and indeed young nurses and midwives, because they would have had the same issues, to really step up and provide abortion care, and most particularly seek education around the area of abortion care. So, for instance, when I was a medical student, I received absolutely no education on abortion, and unfortunately, that is still largely the case. So we have an issue that the older doctors who run and control undergraduate medical education have no knowledge or interest in abortion care, and therefore there's no provision in the undergraduate curriculum. But similarly, into the postgraduate curricula of whether it's the obstetricians, gynecologists, or indeed general practitioners, it's been a very difficult issue to try and introduce it into those curricula of GP training and hospital physician training, and very much seeing it as other, different, doesn't need to be part of core curriculum. Now we're making some significant progress, and thankfully it's the young medical students, it's the young doctors who are articulating the need for change and are stepping up and saying we must have this change in our educational provision. And so I'm very optimistic that this will make quite a substantial difference in Ireland. Thank you.
Great. And reflecting on your comments as well as Farid's comments throughout this webinar, we're really hearing that actions need to occur at multiple levels by multiple actors in different ways. Barriers can exist all over the place. They can be imposed by the law or by policies and other implementation guidance, as well as just individual providers themselves or others that are participating in the abortion care pathway. And we received a question about sort of being ready for other potential restrictions in specific contexts. And from our perspective, I think we would say that, this is really about thinking about the holistic enabling environment, what needs to be in place, considering all of abortion care. It's not just about law and policy, it's also about the clinical aspects, it's also about the health system aspects, and really considering all of those components when we're thinking about the provision of quality abortion care. Fiona, I'm going to turn over to you now.
Yeah, thanks. So there are two great questions in the Q&A or question and a comment that relate to conscientious objection. So the question is, if national law says there is a right to object to the provision of abortion, is there a human rights problem from the perspective of the health worker if you remove conscientious objection? And would it be more rights-based to seek to balance a right to object with some kind of robust duty of care provision? And then the comment, I think, also relates to that, talking about a demarcation between the provider's values and the client's rights. So I guess my first answer is, we've already said that international human rights law doesn't require the state to permit conscientious objection, but there may be national laws that do. So it is possible that in a particular setting, there would be, let's say, a constitutional right or something like that to object or to refuse care on the basis of a conscience or a religious belief. And there, you know, one might argue that there is a challenge in terms of rights if you refuse conscientious objection now, or you remove it from the law. Now, what the guideline has recommended, which is in line with the kind of compromise or balance that both the question and the comment point to, is not that conscientious objection would be prohibited, but rather that the state would ensure that conscientious objection does not negatively impact on access to and continuity of care. So it's precisely that point of regulation. So Maeve, in your question, you talk about imposing a robust duty of care with equal legal weight. You know, one way of doing that in a more specified way, you know, is to have this clear regulation of who, when, where, how objection can be exercised. What must you do when you exercise objection? So in terms of referral, for example, and referring to accessible providers, not referring to another objector, which is something that in the evidence base we saw happens in some cases, prohibiting institutional objection and so on. So, you know, what is going to work or be achievable in any particular setting in terms of the law and regulation will of course be best determined by the people working in that setting itself. But what the guideline and international human rights law, I think, provide, as the Ethiopian example that Farid gave us illustrated, is a set of parameters, you know, for the regulation of conscientious objection. If you are going to permit it, then the counterbalance needs to be this regulation, these restrictions, and these obligations on people who are exercising objection. And I think, you know, I don't know if it's a satisfactory answer to your question, but it's not necessarily that helpful to think about this if you're from a starting point of the right of the health provider. If our starting point is the obligation of the state to ensure that refusal by a provider does not undermine the rights of the person seeking abortion, then the question of balance is a little bit, I think, more, it's a little bit more accessible to think about how you strike that balance and regulate objection.
Great, thank you. And I just want to add as a clarifying point. So when we looked at the evidence for the conscientious objection intervention, we looked at conscientious objection as a whole. We didn't specifically look at the ways in which states are regulating conscientious objection. So we are undertaking that review now. So just to say, stay tuned, there may be more evidence there as well.
I think if I may add something here, Antonella,
yeah,
I think, you know, this issue of, you know, conscientious objection, sometimes, you know, it can be a very slippery slope where we're coming back when it might be difficult, because we have seen cases where some care providers refuse to operate on someone with ectopic pregnancy because there was a positive fetal heartbeat. And remember, this can have a deadly complication to the woman. And when you try to explain this kind of situation to most people, they will say, no, this is, you know, expected from the provider, and the provider should not be in a position to deny such service. And, you know, this care provider is actually expected to provide this service no matter what. But I think we should ask again another question. Whose reasonable expectation are we talking about here? Are we talking about the reasonable expectation of the client? Are we talking about the reasonable expectation of the, you know, the ethical professional conduct? A law? Whose reasonable expectation? I think the client has to be the center here. Otherwise, you know, we will end up, you know, with a terrible consequence to the women and girls who are, you know, seeking care. Over.
Great, thank you. Mary, you had your hand up before. Yeah, go ahead.
Yeah, it was related to an earlier point. It was in the questions about the Roe versus Wade decision. I think, I mean, besides the fact that, you know, we're upset and worried about it, I think it's done two things. It reminds us, one, that gains made can be lost, and that's a really important thing to keep us strong. But it also I think the most important point out of it is that it shows that we need to lean into being an international community. We need to lean into the fact that we can all learn from each other, and we need to follow best practice and evidence, which is what this WHO guidance is about. And I think there's a huge strength to be gained there, and it reminds us that none of us are isolated in this, that there is a huge amount of support and education and evidence that can be garnered from discussions like this, but particularly from things like the WHO guidance. And it's a useful reminder of that. Thanks.
Great, thank you. Okay, so at this point, we are going to continue to open it up for additional questions. So we're looking for additional questions here. There's been a comment about additional ways in which conscientious objection can be regulated by compensating providers appropriately. Other questions here that people have before we turn back over? Maybe while we're waiting, Fiona, if you have any final thoughts for us.
I mean, I think, you know, this has been a really rich discussion. And one of the things that has struck me is the similarities in the ways of trying to address these challenges that we see across different systems, and also the resonances between the kinds of mitigations and guidance and so on that both Mary and Fareed were talking about, you know, in terms of things that are helpful or that work, as well as things that are challenging, with what we saw in the evidence base, you know, that underpinned these recommendations. So that, you know, as you said already, Antonella, you know, one of the key things for me from this conversation is thinking about where within the regulatory scheme, where we might be experiencing kind of roadblocks or obstacles to quality care, and understanding or seeking to understand what can be done there without necessarily needing right now to change the law. So these immediate steps, whether it is, as Mary was saying, education, or Fareed was talking about task sharing, you know, or thinking more about what do we do in practice that the law doesn't necessarily require us to do, but which in real life means that abortion is less accessible. And when they relate to things that the recommendations touch on, then the recommendations, I think, give this evidence base of reassurance to say we can actually change this, bearing in mind, of course, the criminalization point is a kind of fulcrum point, and recognizing that criminalization may create caution or hesitancy in taking steps of this kind. So I see we have lots of questions coming in. I'll just hand over to you.
Fiona, one of the things that we now need to do in Ireland, and this is the responsibility for us both as providers and our advocates in the area, we effectively need to map the patient journey from beginning to end and look at all the potential points where issues that are not just about the law but are about regulation and how we interpret regulation can be addressed, and flipping it always over to, as Fareed said, a patient focus as opposed to a doctor or provider focus. And that there's so many parts of all those moving things that we can now address, whether it's education or regulation or attitudes. So, for instance, we have our abortion providers training meeting in October, and it's our annual meeting. It's fantastic. But I've now introduced a slot into it that we're going to discuss the new WHO guidance, but not necessarily just from all the parameters, the 4 substantive headings on the bullets that Antonella put up earlier, but really from a point of view of where do we lie within it? Where's our responsibility? What are we doing? What could we do different? How do we need to reframe the care we provide? How much have we internalized the criminalization? How much have we internalized the shaming and the othering, and allowed it be formed and regulated in certain ways and provided in certain ways? So I think we have a very significant piece of work to do there, but it's about raising that awareness and starting that journey. Thank you.
If I can just come in, thanks, Mary, to respond to a question from Mariana, who asked about how you can make conscientious objectors accountable if they do not comply with the regulations. Look, the way it would work in any particular setting will really depend on how the health system is regulated. But, you know, if a provider or a health worker doesn't comply with the ethical code or the requirements of the law in any other setting, you could think about what you would then do, you know, complaints to your regulatory body or seeking to have professional repercussions, as well as, you know, frankly, like social regulation among health workers, and, you know, the reinforcement of a kind of professional social expectation of compliance with these regulations and ethical expectations. So, you know, it might not make sense in every system to say, I'll report the doctor, because maybe that is the only doctor available who you have to engage with for all your other healthcare. So it might not make any sense to do that. But, you know, within certain systems and their own dynamics, you know, we can think about how to make health workers accountable for non-compliant or non-rights-based exercise of objection in the same way as we would make them compliant for practices that are not, let's say, compliant with their professional obligations in any other setting.
Great, thank you. So just being conscious of time, we have 6 minutes. I just want to touch on 2 things. So we had a question come in about self-management and thinking about whether or not there's a way forward there, in particular in terms of international law, but just from the perspective of the guideline, just to note that we have specific recommendations around self-management. It's, you know, one way in which we talk about abortion care, but it's also important for us to remember that 1, not everyone is eligible for self-management. 2, we want to make sure that all parts of the enabling environment exist so that people can be supported whichever way and however they want to access that abortion care. And for some people, that might be complete self-management. For others, it might be coming in and out of the health system at different points. And so we would, again, want to return to that enabling environment and consider all the touch points, as Mary had mentioned as well. So sort of thinking about where are all the action points too. And then the other thing is, as a reminder, the evidence base for these recommendations all exists within our evidence to decision frameworks. The link was provided earlier on in the chat, but we can provide it again. And just to note that for pretty much all of these reviews, they've all been updated actually with even additional newer information since the time that the evidence was reviewed. So additional studies exist in the systematic reviews related to these interventions. So at this point, we are going to actually turn back over to the slides. So Karen, I'll ask you to put those up, please. Next slide, please. Great. So we just want to thank everyone for joining us today. And before we close, I want to highlight again for those who may have missed yesterday and Monday's webinar some important information related to using the guideline. Next slide, please. So there are several ways to access the guideline. It's available in an interactive digital format as well as in a PDF. And we also have an executive summary which consolidates the recommendations into one place available. And these things are available in multiple UN languages. Next slide, please. We are also planning several derivative products. And so these include things like an operational guidance, both on how to operationalize these law and policy recommendations, but also an updated version, for example, of the clinical practice handbook that accompanied our 2012 safe abortion guidance. We are developing decision support tools, as well as pocket charts or cards for health workers and other informational materials. Next slide, please. And then we have other resources that are available related to abortion care. So many of these can be found through our link on the WHO topic page on abortion. But we have things like social media tiles. I mentioned earlier our global abortion policies database, as well as articles and fact sheets. Next slide, please. And of course, we've now completed all 3 of our law and policy webinars. And so we really want to thank everyone who stayed with us throughout all of these and those who may have joined in for 1 or 2. Next slide, please. But as mentioned at the start of this webinar and in previous webinars, you will be able to view it again and also share it with others. The presentation will be shared in both PDF format as well as the links to the recordings in a few days. And so you'll be able to click directly on these links once these go out to you. Next slide, please. We also invite you to stay tuned for future webinars. And if you're not already a member, please join the IBP platform. This is a digital space where you can get updates on other upcoming sexual and reproductive health and rights webinars and events. You can receive news about WHO guidelines and other tools. And you can also interact and exchange knowledge with people around the world who share an interest in a variety of SRHR topics. Signing up is free of charge, and you simply can go to the ibpnetwork.org site to do so. Next slide, please. Being a member allows you to join a range of communities of practice, including one on comprehensive abortion care, which allows you not only to engage in discussions, but also receive updates on abortion research, share your own work, and pose questions to others in the community. Last slide, please. So thank you very much for your attention, and we look forward to seeing you all as IBP members and in attendance of future webinars. We very much want to thank our esteemed panelists today for joining us, and thank you so much, Fiona, for helping me to lead this. And so at this point, we're going to go ahead and close the webinar, and we look forward to seeing you all in the future.